said, feel free to ask your questions in the chat. I just wanted to point out that we will not be able to give you personal medical advice. Please consult with your healthcare provider to answer any specific questions that you might have about your specific case. But that being said, it's my pleasure to have with us today Doctors Oksenhendler, Josh Brandstadter, and Dr. Gordan Srkalovic, if I said that correctly, I apologize. And to start us off, I'd like to introduce Dr. Oksenhendler. He is a professor in the development of clinical immunology at Hospital St. Louis in Paris, and he has been one of the leading experts worldwide in advancing Castleman disease research, leading to improved treatments and therapies for Castleman's patients. So again, we're so excited to have him and Josh, as well as Gordan on board. So Dr. Oksenhendler, please take it away.
Thank you very much for this very kind introduction. I'm really pleased to be with you today and to discuss management of UCD with you. So as you said, I'm working in Paris. I'm the head of the French National Reference Center for Castleman disease, and we have collaboration with the CDCN for years now, and we have also a network in Europe. So we are talking today about unicentric Castleman disease, UCD. What are we talking about? This disease is mainly characterized by enlarged lymph node, usually in a single region, with no or mild symptoms, and often discovered by chance. It's a very rare disease. The incidence is probably around 10 patients per million person diagnosed each year, so that's very few. The cause is yet unknown, but we have serious leads, and you will see thereafter with Josh talk what we are talking about. Usually, as I said, it's a disease without any symptoms or very mild symptoms, but sometimes it could be associated with a rare but very severe complication, which is PNP, which is paraneoplastic pemphigus. We will talk about this disease a little bit later. Overall, the survival is very good, above 95%, which is very close from the general population. There are sometimes difficulties to classify or categorize patients into unicentric or multicentric disease. And why that? Some patients may have several lymph nodes in the same region or area, and most of these patients have no symptoms, a normal lab test. So they are very like UCD patients. But some patients may present with inflammatory symptoms, just like patients with IMCD2. So as you can see, there could be a spectrum between UCD and MCD with sometimes difficulties to characterize a diagnostic, to characterize a patient into one or the other of these diagnoses. Well, let's talk about treatment now. If you look at a textbook, it is very easy. It just said, just remove it. And why is that? It's because complete surgical resection is associated with cure, with a very low risk of relapse, below 5%. So you see, I could stop my talk at that point, but in fact, I cannot. And why is that? It is because, in fact, in the real life, about 60 to 70% of the patients cannot undergo surgery straightforward. And why is that? I mean, 60 to 7% can undergo surgery straightforward. And why is that? What about the 30% of the patients remaining? Well, let's have some definitions before going to these points. We have to understand some key terms. What we call resectable, it's just mean able to be removed by surgery, and non-resectable, not able to be removed by surgery. And the surgical excision is the removal of the mass by the surgeon. So we can have a partial or a total resection excision. Now, let's come back to the diagnosis. How did we get the diagnosis? We could have two different situations. Here you have a patient with a solitary mass in the abdomen. You can have the diagnosis using a needle biopsy during a CT scan or ultrasound procedure, for example, or you can have a partial surgical biopsy. In such a case, the lymph node is not removed. So you've got the diagnosis, but not the cure. In another situation, if you go straight forward for a complete resection of the lymph node using surgical biopsy, you will have the diagnosis and the cure. So it could be very interesting to see if we can predict the diagnosis of UCD prior to the biopsy. And in fact, in some cases, it could be possible. In very typical cases, such as this one, the radiologist may suggest a possible diagnosis of UCD. And this is in the case of a big, large single mass, distinct from an organ, with a very clean-cut shape, as you can see on this one, and with sometimes peculiar feather on the CT scan, such as few calcifications, and most importantly, these lesions is hypervascular. It's shining, it's bright white, you see, on the CT scan images. So when the radiologist suggests such a possible diagnosis, at that time, if the procedure is non-invasive, you can ask the surgeon to go for a complete resection straightforward. Otherwise, the treatment could be easy, not so easy, difficult, very difficult. And it depends of a few boxes you have to click. If you can click all these 6 boxes, it will be easy. The first one is the lymph node is just one single lymph node, as assessed by a CT scan, or even better, using a PET-CT. The pathology on the biopsy is classic hyaline vascular type, which is the usual type in the unicentric form of Castleman disease. You have no symptoms, no compression, no inflammation, no fever, normal blood test, no associated complication, and the surgeon says it's easy. I can do a non-invasive surgery. In such a case, go for surgery and cure. That's the easy way. Not so easy. One of several boxes cannot be clicked. In such a case, the first one, it's not a single lymph node. If you look at this MRI, you can see that yes, you have several lymph nodes in the same area. This is what we call oligocentric or regional Castleman disease we have talked about. So when we are facing such a case, we must know that in fact, most of these patients are not really different from patients with classical UCD. And the goal of therapy will remain the same, which would be surgery, try to remove the largest mass, and if even if a few small lymph nodes remain after surgery, they may involute thereafter. So surgery is still possible in such cases. Second situation, there are symptoms. The patients experience fever, weight loss, and the blood tests are not normal, including inflammatory markers such as high CRP. And if we already have a biopsy, in many cases associated with these inflammatory symptoms, it won't be anymore a hyaline vascular type, but a plasma cell type. And this concern about 10 to 20% of the patients. And this is quite different because these patients looks like idiopathic multicentric Castleman disease. However, the tumor is localized. And in such cases, we would probably recommend to start with a treatment which is usually used for IMCD and which are usually based on anti-IL-6 therapy. And then, in the second step, go for surgery. These patients may have an increased risk of relapse because the disease might be slightly different than classical hyaline vascular UCD. Third situation, there is a complication. And I told you that UCD could be associated with a very severe complication, which is this one. And this one is paraneoplastic pemphigus, PNP. What is PNP? PNP is an autoimmune disease. It means that in this disease, you have antibodies which are directed against proteins that ensure the cohesion between the skin cells. So when you have these antibodies in the skin, it leads to blistering and peeling of the skin, giving it's like a burn victim, as you can see on these pictures. And in addition, these antibodies could also be active against the cells of the bronchi, leading to irreversible destruction of the lungs. So we are talking about a very, very severe condition. Fortunately, a rare complication of UCD, but we must be aware of some warning signs as symptoms of PNP often precede the detection of UCD. And these could be as, usual as itching, small blistering lesions on the skin, small haftous lesions in the mouth, unexplained cough, shortness of breath. All these symptoms should warn and lead to look for a possible PNP-associated disease. In such an association, the pathology of the UCD lesions may be quite different and may suggest a more aggressive tumor, which is called follicular dendritic cell sarcoma, FDCS. So if we have first the diagnosis of PNP, which is the majority of the case, we have always, and the dermatologist should know that, we have always to look for lesions of UCD because you have absolutely to control UCD to cure PNP. It's mandatory. And in some cases, you first have the diagnosis of UCD and you must look for symptoms that could suggest associated PNP and look for the presence of these antibodies, specific antibodies in the serum or in a skin biopsy. So regarding the treatment of these associations, we must be aware of a possible risk of PNP lesions flare just after surgery. And therefore, we suggest an intensive treatment of PNP before the resection of the Castleman lesions. And these usually associate steroids, immunoglobulin, and rituximab. Last case, the difficult case. The difficult case, the surgeons say, well, I don't want to go there. It will be a mess. It will be a very invasive surgery. I don't think I can do it. So what can we do? We have possibly 5 different propositions. The first one is wait and watch. Look at this boy. When he was 13, his mother thought he was hunchback. She was a very attentive mother, so she thought he was hunchback. So he had a chest X-ray. Well, he was not hunchback, but the chest X-ray revealed a single mass in the mediastinum, which was very close to the big vessels. This boy had no symptoms, normal blood test, and the biopsy revealed classical hyaline vascular type Castleman disease. As I say, the surgeons say it will be a very, very invasive procedure. And the mother said, no, we won't do that. And they went away. And I saw this boy 14 years later. And at that time, he was a 27-year-old man. His girlfriend thought he was handsome. And he still had no symptoms, still normal blood test. And the chest X-ray is remarkably superposable to the first one. There is no progression over 14 years. So in such a case, at least, wait and watch was a good possibility. Second possibility, embolization. What is embolization? This is a procedure where we proceed to an occlusion of the vessels that supply the tumor. It could be performed pre-op, it could be performed to stop the bleeding or as a treatment. And this is possible because UCD is a hypervascular tumor. That's why the surgeon do not like very much to go for surgery for such lesion. You know, it bleeds very easily. And you can see easily you can see this on this radiography showing the vascularization with a vascular blush, vascular recruitment of enlarged vessels. So you must be very careful before doing this procedure to carefully analyze the connection between the vessels and the adjacent vessels, especially when you are in the thorax. And then we use small particles to occlude the vessels. And one point which is important is that this procedure can be repeated. Third possibility, reduction medical therapy. A number of drugs have been used to try to shrink the tumor. This is what we call debulking. Steroids, you know, everybody knows, rituximab, an anti-B cells monoclonal antibody, cetuximab and tocilizumab, these monoclonal antibodies that are usually used in the treatment of IMCD, immunosuppressive drugs such as sirolimus or chemotherapy. All these drugs have inconstant efficiency, but worth trying because sometimes it may shrink a little bit the tumor. But of course, we must be aware of some possible side effects of this treatment. For steroids, they are very well known, especially by the woman, because of the weight gain, the moon phase, the irritability, diabetes, gastritis, etc., etc. Rituximab, the main problem should be long-term possibility of infection after reaching low levels of serum antibodies. Cetuximab and tocilizumab could be associated with infusion reaction and sometimes infection also, and sirolimus, mainly mucositis. So let's come now for the fourth one. And the fourth one is what we call targeted therapy. And this is the teaser for Josh's talk just after me. This is a very weird sentence. You know, there is a growing evidence for clonal origin of the UCD lesions associated with somatic, which means acquired mutation in some genes in stromal cells. Woo! What does that mean? I tried to explain it. Well, in a lymph node, you have the normal immune cells, the most common immune cells, which are lymphocytes. But you also have other cells called stromal cells, which are very important cells to help communication between the immune cells, between the lymphocytes. In these cells, just as in other cells, we have genetic material, genes, and as you know, genes are coding for proteins, and proteins have functions. And I'm sure you are more familiar to these notions now with the COVID epidemic, and especially about the notion of mutation. Mutation, when there is a multiplication either of the virus for the COVID or the cells in such a case, during this multiplication, they could have errors in the coding. A letter could be changed. And if a letter is changed, the protein encoded by these genes will be changed and its function may be modified. And it has been shown that in UCD, for specific gene, one specific mutation was associated with an increased function of one protein. And this is an interesting lead for a better knowledge of this disease. And why it's so interesting? It's interesting because we already have inhibitors of these proteins. Last option is radiotherapy. It has been proposed for unresectable lesions. It's effective, but we have serious limitation, especially when we are dealing with young adults and it depending on the localization. It could be associated with organ damage, a higher risk of breast cancer when we do radiation on the thorax, vascular lesions, for example. However, it can be used in some locations in the body where radiation therapy is not high risk, such as armpit, for example. So we can keep this somewhere. So to summarize, remember the 6 boxes. You have to click the boxes, keeping in mind that the goal is surgery, but that we also have other possibilities instead or before surgery. And this leads to treatment guidelines that have been recently published by Fritz van Rij for the CDCN. So it starts with the evaluation of resectability. If it's resectable, that's easy. As I said, surgery. Not resectable, if the patient asymptomatic, in such a case, we can think about just observation and a period of wait and careful watch. If the patient is symptomatic, what is the symptoms? If it is compression or inflammation, the treatment might be different. In case of compression, we will probably use steroids, rituximab, or embolization to try to shrink the tumor. In case of inflammation, we will go for treatment that are usually used in IMCD to control inflammation, and these are anti-IL-6 therapy. And then we can have a reassessment. The tumor could become resectable, so at that point we can go back to surgery. And if it is still not resectable, we will have to discuss embolization, as I said, could be repeated, just observation, targeted therapy in the future, or in some cases, radiation. Last, to finish my talk, let's briefly discuss what you can do after receiving a UCD diagnosis. The first is to locate an MD who is experienced with this treatment. And this is now easy using different websites, the CDCN website or website across the world in Europe, France. You can have this information. Learn about CD and your particular subtypes. This is true, but please go to specific professional website. And I can again recommend the CDCN website. An important point, monitor your symptoms and treatment. This could be very helpful when talking to your doctor. And these key symptoms are the inflammatory symptoms, night sweat, fever, weight loss, could be also pain or skin lesions. It's also important to keep track of critical lab values. Why it is important? It's important because it provides an objective measurement of the disease and the response to therapy. It could also assist in selecting therapy by predicting response. So it's important. And we are talking about very simple lab tests. The blood counts, hemoglobin, platelet counts, inflammatory markers such as CRP or ESR, and the kidney and liver function. That's enough, usually. Last, please keep a positive attitude. you know that most UCD patients can return to a normal lifestyle, eat a healthy diet, exercise. This is not specific for UCD, as you may know. And of course, seek support as stress is very common in such a disease. And finally, you may have bad moments, but don't be afraid to keep moving forward. The future is bright. Thank you very much.
Thank you, Dr. Oksenhendler. That was a really great talk. And so we're gonna hold off on answering any questions until after Josh's talk. So I'll briefly introduce him. So Dr. Josh Brandstadter comes to us from the University of Pennsylvania. I know him very well. He is a physician scientist here. So in addition to seeing and treating patients, he's also working to understand the pathophysiology behind unicentric Castleman's disease. So he's really, an expert, trying to figure out how, the mechanisms behind it and how we can better treat it. So Josh, I'll take it away.
Thanks so much, Melanie. Can everyone see my screen all right? Awesome. So I do want to make sure we have time for questions, but I also wanted to take the moment to share some of the things that we've been working on in the laboratory in terms of understanding the big question of what's causing Castleman disease. Why did I get Castleman disease and someone else not? And I've been working on this project with my research mentor, Dr. Yvonne Milliard, and we've been very successful in getting support both from the Castleman Disease Collaborative Network in addition to the Orphan Disease Center here at the University of Pennsylvania. We've also received support from other rare disease advocacy groups such as the Uplifting Athletes Group, and the American Society for Clinical Oncology has given us funding support as well. So there's a lot of interest from different research organizations into supporting work that helps us to understand what causes Castleman disease. And the idea is that by better understanding what causes the disease, we can inform better ways of reaching a diagnosis and treating the disease as well. So traditionally, when we think about Castleman disease, we often think about big lymph nodes. Lymph nodes become big because white blood cells, in particular kind of white blood cell that likes to use the lymph nodes as an organizing center, the lymphocytes, accumulate in the lymph nodes and cause it to swell. In the context of a lymphoma, all those lymphocytes, all those white blood cells are actually copies of each other, and they cause the lymph node to get big. But when we look at a Castleman disease patients, the large lymph nodes, the white blood cells that make these lymph nodes so large generally look fairly normal. They're not copies of each other. They are genetically dissimilar, and they look almost like a healthy immune response, just inappropriate. So therefore, we're starting to turn to other cells that are there in the lymph node called stromal cells. They form the walls of the lymph node. They compartmentalize the different rooms of the lymph node. And they're not just kind of the bones of the house per se of itself. They also are now increasingly understood to play a role in directing the white blood cells and telling them what to do. In fact, they actually look histologically abnormal when you look under a microscope at a Castleman lymph node. You can see these cells these stromal cells look aberrant under the microscope in a Castleman disease patient, which first got us to ask whether or not that sort of abnormal appearance of these cells actually means something in terms of what causes the disease. And so these cells not only play a role in, as I said, forming the structure of the lymph node, they also help sort of direct, as kind of air traffic controllers, telling the white blood cells where to go and whether or not to mount an immune response or to dampen an immune response. And since they've been established as playing roles in immune responses in the context of infection or an autoimmune disease, it makes sense that they could also be causing other diseases relevant to human biology, including Castleman disease, where we have an inappropriate immune response that seems to fall short of a classic autoimmune disorder where the white blood cells are clearly directly attacking other tissues. And so we ask whether or not these stromal cells are what's going wrong in Castleman disease by causing inappropriate signals to activate the white blood cells without a clear trigger. As the preceding talk mentioned, there's some suggestion that these cells actually might be copies of each other in a Castleman disease tissue. So when they look at patients who have unicentric Castleman, look at their lymph nodes, they can use special genetic tests to show that some white blood cells are, that some cells in the lymph node are in fact copies of each other, but not the white blood cells. The white blood cells genetically are not copies of each other. But that then asks if something is a clonal growth, is if it is in fact cells that are copies of each other, and it's not the white blood cells, what else could it be? And this would leave these stromal cells as being a clear candidate, as being cells that could be in fact growing in an inappropriate fashion, almost like a like a colon polyp appears in the intestine, in the colon, when you get a colon gets removed with a colonoscopy. Maybe a similar sort of growth is happening in the lymph node, but in these cells causes it to start an inappropriate immune response. In fact, in one case series out of China, about 17% of patients with unicentric Castleman disease actually had this particular mutation in this gene called PGFR beta, and I know this was described before. When they look at which cells in lymph nodes seem to express this mutant PGFR beta gene, it does seem to be in the stromal cells, the non-white blood cells that are expressing this mutant PGFR beta. And then this suggests that maybe this mutation could be a cause of unicentric Castleman disease. And what's so wonderful is that there are already FDA-approved, commercially available oral medications that are known to blunt PGFR beta signaling in other conditions where this gene is known to cause a problem. And this was one limited case series of about 40 different patients where they found about 17% have this exact mutation in PGFR beta. We're going to be confirming that soon with in our own cohort about whether or not this mutation is in fact there. And I would say, regardless of whether or not you have or do not happen to have this mutation yourself and have maybe unresectable disease or systemic symptoms despite complete resection of the disease, there may be even a greater number of patients. Existence of this mutation may inform more generalized biology and may show that treatment of PGFR beta may even help patients who don't happen to carry this exact mutation. So we're asking, in addition to, can we confirm this finding and show that there are in fact PGFR beta mutations in Castleman disease patients in our own cohort, but are there other very similar undiscovered mutations, particularly in the same pathway, that may be present in unicentric Castleman disease patients, and then exactly which and trying to nail down exactly which cells do in fact carry this mutations. We're doing this in the context of work in culture, trying to show in cells that we can grow in culture what this mutation does to those cells and how we can treat it in culture with different commercially available oral medications, and then also using this to help make a mouse model for Castleman disease where we can really create the same experiences that patients are having with enlarged lymph nodes in the mice in order to better understand the biology of the disease and lead to new ways of diagnosing and treating it. We're also taking a much broader pipeline beyond just the cell culture dish in the mouse and testing human lymph nodes directly to both discover whether or not they have this mutation, whether there are other related mutations, and better identify the cell type that carries these mutations, and look generally at these stromal cells in patients with Castleman disease and in a more comprehensive way, and say, are these cells behaving abnormally in Castleman disease patients? And for that, we hope this will overall help patients who have bulky disease, who have unresectable disease, who have recurrent symptoms despite resection of disease, and also, since unicentric and Castleman disease share an underlying biology and that they look the same under the microscope. That's what unites these different diseases. We hope that insight into unicentric Castleman disease will also inform what we could do for multicentric Castleman disease as well. And so we're using advanced technologies, flow cytometry, single cell, next generation sequencing technologies in order to do a lot of this work with the ultimate goal of finding better ways of diagnosing Castleman disease, because I know for a lot of patients that the lead up to the diagnosis and the need for for whether it's pathologists who disagree at different centers, or finding a center that has experience with Castleman disease to help you shore up your diagnosis. So we hope our work will help make diagnosis a lot easier by finding new ways of better, more specifically testing for Castleman disease, and also finding new ways of treating Castleman disease, since obviously there's a lot of needs still there. And I'd like to just last make a pitch that all this work, really is dependent on us working collaboratively between physicians, scientists, and patients all together here. And it's ultimately dependent on access to patient tissue. So your ability, if you have a surgery coming up over the next week or two, or maybe down the line you're going to get some sort of biopsy or surgery, please keep us in mind and reach out to the CDCN to tell us that you have a planned surgery coming up to remove lymph node tissue, and then that you'd be willing to donate a portion of that that's not needed for your clinical care to the laboratory, where we can then undergo testing in order to learn more about what's causing the disease and help more patients down the line, so that the future patients can have a better, an easier experience with the diagnosis, and hopefully new treatment options available to them. I think we can now start the question and answer session.
Thanks very much, Josh. So I just wanted to finally introduce Dr. Gordan Srkalovic. Dr. Srkalovic, if you want to know, you're coming to us as a hematology specialist from Lansing, Michigan. So if you just want to say hello, so we know you're there.
I'm here.
Thanks so much. So we'll just jump right into the questions. I'll just start off with the first one. So I think the first one is really related to as a question around UCD and its connection to autoimmunity. So why is it recommended in the UCD workup to test for ANA, and what follows from a positive test result? And if you just can briefly talk about the connection of autoimmunity and UCD.
Yeah.
So I can start, first I want to say that it's very hard to say anything new or really important after this excellent presentations. So I will just say, from the clinical standpoint, ANA is done really to find out if patient has possibly connective or autoimmune disease. But ANA is very non-specific test, and even if it comes positive, there is need for additional testing, like evaluation of ENA and anti-dsDNA antibodies. So just a simple positive ANA is not sign that patient has autoimmune or particularly connective tissue disease, but additional testing is necessary. And I think a connection between Castleman's and autoimmune disease, I think Josh or Eric can probably comment better than I do.
Okay, I cannot comment on the antinuclear antibodies. I would not recommend to perform the antinuclear antibody in all UCD. If you have a classical localized hyaline vascular asymptomatic UCD, there is no use for this test. This could be useful when we are on the borders and when we have some doubt about the diagnosis, which is a patient with presumably localized disease, but inflammatory symptoms. The pathology is plasma cells, So at that point, you have to look not only for antinuclear antibodies, but symptoms suggesting another associated autoimmune disease that could be lupus, Sjögren, Still disease, or otherwise. But the clinical symptoms are much more important. If we have a context that could suggest another disease, that could be a differential diagnosis.
I completely agree. ANA becomes very important only when you have to always start by treating the patient first. And the ANA becomes important only in the context of other symptoms that might be suggestive of another rheumatologic illness that for which a Castleman disease biopsied lymph node may only be showing a secondary epiphenomenon to the underlying autoimmune disorder. And so that's what, so if they have symptoms of another autoimmune disease, but they just also happen to have a node that showed Castleman under a microscope, it's more helpful then to diagnose that autoimmune disorder. And the Castleman is then in that context reactive. I certainly saw a patient where she had symptoms of dry eyes, dry mouth. That was classic for Sjögren's. She just happened to have a lymph node that was suggestive of Castleman disease. And so this is a case where they're treating the biopsy result and not the patient. Her problems were dry eye, dry mouth. And so always treating the patient first and then thinking about the numbers is probably the best guide.
Great, thank you for, that's very helpful. The next question from Esther Miller, is Rituxan recommended for long-term use in UCD?
I personally use Rituxan as a bridge, and we don't use Rituxan generally even in lymphoma as a long-term disease. We use in some lymphomas as a maintenance therapy, but we shouldn't forget that Rituxan is immunosuppressive. So long-term use of Rituxan could be beneficial for some aspects of disease, but will produce significant complications on the other side. So I use Rituxan, and I used in just few cases with unicentric Castleman disease, and that was actually more push from surgeon who told me I cannot resect this disease because of location, because as Eric mentioned, it's a very hypervascular. I'm concerned that patient will die on the table. So why don't you try to use something to try to shrink this, make it more operable, and then I will go there. And it actually worked, but I use it only as a bridge to, to surgery and to resolution of disease.
Totally agree.
Yes, we also always want to be mindful about rituximab in the era of SARS-CoV-2, since humoral immunity that's mostly suppressed by rituximab can make you more at risk to severe SARS-CoV-2 infections and also diminish your ability to respond to the vaccine.
Okay, great. The next question also comes from Lennart, and it's really around polyneuropathy. So is there anything kind of specific to UCD patients and polyneuropathy, perhaps also, after surgical resection of the lymph node?
Well, polyneuropathy is more often observed in patients with IMCD, or at least the plasma cell type of UCD or regional Castleman disease. And this is the major neurological complication that could be associated with Castleman. The other one, which is much more frequent in UCD, is myasthenia, which is a neuromuscular disease. It's also an autoimmune disease that affects the connection between the nerves and the muscles. And the patients have just weakness. They suffer of diffuse weakness, increasing during the daytime. And sometimes the diagnosis is difficult if you don't think about that. But it's another complication associated with UCD, and PNP and myasthenias are the two major complications. This is the other one.
Yeah, Castleman is a rare disease. Neuropathy is unfortunately very common. I think making sure that you have taken a very comprehensive approach to what's causing your neuropathy is really important. So making sure it's not that you have a pinched nerve in your back or you have diabetes causing neuropathy and not just immediately blaming the Castleman is important. Making sure there was a full examination about why you have neuropathy is very important. Sometimes it's helpful if you can find evidence of a paraprotein, a protein in the blood that's not supposed to be there, which your oncologist can check for, can sometimes help better associate Castleman disease or any other sort of blood problem with neuropathy.
Yeah, I agree. I think with neuropathy, I think the most important is to really rule out other causes and do very, extensive evaluation, because ultimately neuropathy is really something that influences patients' quality of life and is usually a lifetime problem that patients are, dealing with. Unfortunately, we don't have good treatment, or we don't have actually any treatment for neuropathy. So it's very important to find the cause, and if it can be treated, cause can be treated and ultimately could help patients.
Great. Next question from Jennifer Winter. If you've never had abnormal blood work or ANA before or during your original diagnosis of UCD, what are the markers to look for later when your symptoms resurface?
So I'm not sure I understand questions. So patient with UCD without any abnormal blood tests and had surgery or had treatment and then disease came back. Is there any test that can help in identifying that? Is that?
Yeah. Yep.
Oh, okay. I'm not, especially if patient didn't have any inflammatory component in his disease, I would be very surprised that patient will come with the recurrence of disease with the different type of disease now with inflammatory component. I had very few, actually couple of patients who had recurrence of disease with the UCD after like 20 and 25 years, and disease came back the same. At the same site, same characteristics, didn't show any difference. Patient was just symptomatic. In both cases was in the chest, so patient had increased shortness of breath, and then imaging studies show recurrence of disease. I don't know what Eric and Josh have experience with that, but that's my experience with recurrence.
Recurrence is certainly rare, though it can happen. Patients who have residual symptoms despite complete resection of their unicentric Castleman disease can sometimes have a waxing and waning of those residual constitutional symptoms. It doesn't work for everybody, but in those instances, I do like to try to follow sedimentation rates, see reactive protein. These are markers of generalized inflammation that can sometimes correlate with systemic constitutional symptoms despite complete resection from unicentric Castleman disease.
Okay, great. Next question from Jenny Bruce. What is the risk of future malignancy with a patient that has a fully resected UCD, and has that been quantified?
I would say we are not even aware of an increased risk in such cases. The question is more to be able to diagnose an associated malignancy, an associated lymphoma at the time of diagnosis, because in some cases you can have a true tumoral disease, lymph node cancer, which is called lymphoma, associated with satellite lymph nodes with an appearance of Castleman. So I would say that the most important is to be sure that beside the Castleman lesions, you don't have a lymphoma at time of diagnosis. But this is mainly a problem which is a problem when we are dealing with multicentric Castleman disease, not unicentric. So if it's not the case, I'm not aware of approved increased risk of developing a lymphoma in such patients. But again, I think that the registries that are currently going on in the world, the Accelerate registry, based piloted by the CDCN, you have European registries, will give an answer, I think, with the follow-up of large number of patients. But for the moment, we have no bad signals of such a possibility.
I agree.
Yeah.
Okay, great. We have a couple more minutes, so hopefully we can answer a couple more questions. What does ALK overexpression have to do with UCD and its treatment?
Well, the only thing I'm aware of is that in a tumor which is very close to Castleman or could be associated in some patients, so it's called myofibroblastic tumor. It's another rare disease, and in some cases, these diseases have been shown to have genetic abnormalities involving the ALK gene with a fusion protein. So in some cases, but I'm not sure we are still talking of UCD. It's a closed disease with a characterized genetic abnormalities involving ALK, but I'm not aware of ALK involvement in the classical Gallien vascular type of UCD. Maybe Josh would like to comment this.
It's a very sophisticated question, and I don't have a equally sophisticated answer to it, unfortunately. I agree. I think about ALK overexpression and related conditions, and I don't know about its significance or for unicentric Castleman disease.
Oh, right. I agree.
Okay, and I think we have one more from Jennifer Winter. Are there vascular issues that have been found to be prevalent in UCD?
I'm not aware of, at least in my practice, I didn't see vascular. I would just, because we are finishing, I would just, reiterate what Eric put in his last note in presentation. What I found that patients with UCD very often have psychological problems. And in some way, they are can understand that they should be cured, but that very fact that they had UCD, it seems that influences the way how they see themselves. So I think that's a serious problem. So which means that even when we finish with surgery and we follow those patients, we need to take a really good look at their lifestyle and how they feel, and probably in some cases they need psychological evaluation and help.
Yeah, as it was said, that certainly the lymph nodes themselves have more blood vessels in them. That's one of the histologic definitions of the disease that the pathologists use to help diagnose it. But in terms of like other vascular issues, I haven't seen any of those in unicentric Castleman disease. Certainly, it can be related to constitutional inflammatory symptoms, can certainly cause vascular issues as a consequence of unicentric Castleman disease. So that's probably the best way of tying it together for me.
I guess maybe we have 30 seconds, but is there solid guidance for what's considered a region with UCD?
Well, we are using pretty much recommendations from regions in lymphomas, and that's pretty much defined in lymphoma staging. So we are looking at the lymphatic regions based on the lymphoma staging. And is it defined? Yeah, it's very, very clearly defined.
This question gets at a really important concept, though, that was mentioned in Eric's talk that probably deserves being repeated about this concept of unicentric disease, multicentric disease, and then this thing in the middle called oligocentric disease. I've seen a number of patients who had oligocentric disease. So they had lymph nodes in maybe like 2 different contiguous or nearby lymph areas be labeled by local physicians as having multicentric disease purely on the definition of their having it in more than one spot, even though they were otherwise perfectly healthy, had no constitutional symptoms, had no laboratory abnormalities. And then they very suddenly got told that they have this horrible disease, multicentric Castleman disease, for which there was no cure. And in fact, all they really needed was to have both areas resected, and they then had curative-based therapy. So I think it's very important when we think about these regions that it's okay that just by definition of having Castleman disease affected lymph nodes in more than one area does not mean automatically that you have multicentric Castleman disease and this is your future course. Again, it's always important to treat the patient in front of you and to treat the patient. And so just the existence of lymph nodes in more than one exact area, you could still be more biologically fit with a unicentric picture, which is usually, for the most part, while it can have some low-grade constitutional symptoms, is a disease of big lymph nodes in one spot causing local problems in that area, or 2 spots causing local problems in that area.
Thanks,
Yeah.
Josh. Oh, sorry.
CDCN is redefining that.
Yeah.
Yeah.
Okay, great. So I think we're a couple minutes over time. So I just again wanted to thank Dr. Brandstadter, Dr. Oksenhendler, and Dr. Srkalovic for helping us with this out with this session. And so the next session is going to be in a different room. So we shared the link in the chat. So I hope we'll see you there. And thanks for stopping by.
And I just wanted to piggyback. I really want to thank our expert physicians. It's so wonderful to have all 3 of you. I know how valuable your time is. So the fact that you guys are able to carve out this time from your day, our patients love you guys. So it's always great to have you. And obviously this is a yearly event. So we hope that next year can be in person, and we'd love to have you join us in person where our patients can actually talk to you and engage in person. So again, thank you so much for your time. Thanks to our moderators, Melanie and Johnson, for helping, and patients, we will see you guys over in the next room. I will get it started now. Thanks, guys.
Yeah, thank you all so much. I love my job, but this is the coolest thing I did today, for sure.
Awesome.
Thank you.
Bye.
Thank you all.